Good afternoon out there, everyone. Dr. Tony Brown coming to you with another edition of Clinical Pearls and Profits. So today we are going to talk a little bit about what labs to order for cancer. What labs to order for cancer. Now, you guys know that it is, you have different kinds of cancer, and some of them are more prominent than others, have a higher prevalence in the demographic and in the population, and some of them don't. So what we're going to do is talk about the things that happen most commonly. Okay, the things that happen most commonly. So that said, let's start out with, well, actually, let me ask you guys. You probably have a sense. If I mentioned, I don't know, the 5 most common cancers, which ones do you think that we'd be mentioning today? Yes, prostate, breast, there we go. Yes, lung. Okay, nice. Okay, yeah, you guys are you're hitting the and colon. Okay, nicely done. And the leukemias of the blood, says Sheila, and breast, colon, lung, prostate, says Elizabeth. Great. Thanks, guys. Yep, absolutely. You are on target. All right, so let's go ahead and take a look. Let's start out with prostate. All right. So with prostate cancer, um, currently most of the prostate cancer is identified by screening. And what do we mean by screening? The idea is that um, you're not necessarily treating a patient for any signs or symptoms of that cancer. However, you know that because of a certain age range, because of a certain demographic or certain lifestyle, that you should probably be screening them, right? So most of the prostate cancer is identified in asymptomatic men. Asymptomatic men. Can anybody tell me what is an extremely common pathophysiology that could be mistaken, at least upon examination, digital rectal examination? What is an extremely common pathophysiology that's going to show up in 90% of men over 80 years old? 90% of men over 80 years old. Yes, right. Benign prostatic hyperplasia, right? Benign prostatic hyperplasia. So, if you are a clinician and you're doing these digital rectal exams, um, you want to make sure that you brush up on, the difference in how to uh, preliminarily diagnose the BPH from the actual prostate cancer. And of course, your patient's going to walk in pretty much with the same signs and symptoms, right? A difficulty initiating the stream, um, a difficulty keeping the stream going. If there's blood that's in it, then we might have to talk then about bladder cancer, which we will also bring up during today's class. Okay, so you do your DRE, and the big deal is prostate-specific antigens. Okay, now I know what you're saying. This has been going back and forth for years. Is it useful? Is it not? Is it specific? Um, it's too specific. It's not specific enough, and the controversy still continues. Right? That's why, as a matter of fact, for those of you out there who are studying for whatever board examination you're taking, um, at least for USMLE, for instance, this is not something that is very popular because it's still so very controversial. That is, what levels of a PSA would indicate cancer. So they are used right now in prostate cancer screening, and the jury is still out as to how useful they are, even though they are used. Okay, so needle biopsy is indicated for tissue diagnosis if you have the patient that comes back with an elevated PSA. In other words, that PSA level was just meant as screening. You don't want to get your patient worried just because you do that particular assay. But once that comes back with abnormal levels, now, and especially if you already have abnormal digital rectal exam, now you want to do the needle biopsy. So then a pathologic evaluation of the biopsy will allow for calculation of the Gleason score. This is not the only score that's out there. There's other scoring modalities. We're just mentioning this one. And that would help determine the prognosis of your patient's cancer. Okay, so, what did we find? Pretty much one test. Blood studies beyond the prostate-specific antigen offer little useful information for men with newly diagnosed early-stage prostate cancer. For men with advanced disease, a chemistry profile is going to include at least two things, right? You want to look at serum creatinine, because this is going to give you some idea of kidney and bladder functions. Why? Because the prostate is proximate to the genitourinary area. So with men with advanced stage prostate cancer, there is the possibility that the cancer will have spread into the bladder and or the kidney. So you can get serum creatinine levels, also liver function tests for the same reason. Acid and alkaline phosphatase measurements. Most of the time we think about getting those with, anybody know what kind of cancer do we mostly think about getting an alk phos, just in general? Yes, right? Some kind of bone cancer, right? You can have it also be elevated with pancreatic cancer. Okay, so nice, thank you, Elizabeth. And so for this though, for prostate, the fear is that this would not be very specific for prostate cancer. Sure, maybe you can order it in the advanced stages. If your patient walks in with what you think might be an advanced case, you might be able to order the alk phos if you're trying to get some information about metastasis, but not in the early stages. Okay, your analysis should be performed if those results are abnormal. For instance, you're looking for hematuria or infection, right? Let's talk about the hematuria. So if your patient comes in and they talk about having blood in their urine, right? One of the things you want to ask them before doing the urinalysis is the blood showing up in the beginning of the stream, midstream, or in stream? Right? Those will give you some really good indicators as to whether or not you're talking about something that might be bladder cancer or just urinary tract infection or prostate cancer. Okay, and then of course you need to do some more workups before you actually start treating the patient for cancer. Okay, so that's prostate. How about breast cancer workup? All right, so with breast cancer, can anybody, did I put it on here? Good, I didn't put it on here. Can anybody give me some breast cancer markers that you are used to seeing or hearing about? Nice, okay. Calloantigen, Elizabeth's the CA125, the CA19-9. Both of those are right on target. Okay. Yes, Elizabeth is asking about the luteinizing hormone. And you can also check, so let's start out with this idea of gonadotropins, right? So with women, one of the things that developmentally causes a woman's breast to grow is estrogen. So one of the things that you can check for are estrogen levels. Estrogen is, I know this sounds really strange, but the World Health Organization several years ago, I want to say fewer than 10 years ago, classified estrogen as a carcinogen, guys. It's a carcinogen. Why? Because cancer at its most basic definition is just growth out of control. And so if the job of estrogen is to pretty much act as a growth hormone in women and in men, then it can be considered a carcinogen. That said, it could be one of the things that you would check, right? Estrogen levels. Now you got to think about what are the hormones that would control your estrogen levels. This goes to where Elizabeth is talking, the gonadotropins. You can check gonadotropin releasing hormone levels. These are coming out of your hypothalamus. You can check luteinizing hormone and follicular stimulating hormone. Both of those having a direct or indirect effect on estrogen levels. Okay, so those for a start. Sorry, let me see. There was a question down here. Yes, you're exactly right, George. CA19-9. You are on it. Thank you. So breast cancer evaluation should be an ordered inquiry that begins with symptoms and a general clinical history. This is followed by a sequence that has become formalized as triple assessment, which includes the following. So the clinical examination, right, that's going to give you an idea of whether or not you're talking about inflammatory versus, let's say, invasive ductal carcinoma, right? I'll just pull one out of the air. You want to have an idea of whether or not it's inflammatory or not, whether or not it has invaded certain areas or not. That's going to be the clinical examination, because once you can figure out which one is it most likely, let's see, it looks like peau d'orange, right? Then there are going to be clinical biomarkers that most correspond. And notice, I'm talking about using your clinical examination to home in on your blood markers. Are there blood markers that you can just shotgun shoot out there and just see if anything wrong? Absolutely, right? Everybody knows P53, right? Looking for the P53 protein. Know that that's a tumor suppressor. And the idea is that P53 in its normal job is supposed to stop your cell cycle from going round and round and round and dividing and recreating. P53 stops it so that it can double check what's going on. If you break that P53 protein by genetic alteration or something like that, then it just allows your cells to just recreate willy-nilly. So yeah, you can check for P53, but P53 is probably going to be the least specific thing that you can check for, because you're going to find that in pretty much everything. Same thing with retinoblastoma 1, the RB1. Its job is the same. It's a tumor suppressor. It even acts in the exact same place, right? Somewhere between the G1 and S phase of the cell cycle. It has a different mechanism, E6 and E7, so it has a different mechanism. However, it is also going to be something that won't give you much sensitivity or specificity. So I mentioned those more in passing, that sure, you're going to find them on your lab menu, but they won't give you much help here. So back to the triple assessment. So you've done the clinical examination. Now we're talking about doing the imaging, ultrasonography, or both. And then the needle biopsy. Now, notice the order that this is put in: clinical, imaging, needle. Okay. Um, it's called a triple assessment, not a quadruple assessment, for the very reason that it's only the most progressive of places that are going to be able to supply you with the lab biomarkers and the tests to actually use them as a differential diagnosis. Okay, so that said, let's talk about what type of breast cancer you're going to have the best luck in finding actual biomarkers, so then you can make up your own, if you will, quadruple assessment. That's going to be metastatic breast cancer. Okay, so of course this is cancer that's spread beyond the breast to other parts of the body. For this type of breast cancer, a few specific biomarkers are often useful in selecting the appropriate treatment options. Now notice, um, a lot of times in medicine, uh, the diagnosis and the treatment are one and the same. Okay, this is one of those scenarios where what I'm presenting to you assumes that you've already been diagnosed through the triple assessment protocol with having breast cancer. Now the question becomes, has it metastasized? So now you do biomarkers because, given the assumption that you have the cancer, now the question becomes how to treat it. Okay, that said, these biomarkers can be used to guide the therapy, or just use them right up front when you're trying to identify what's going on. Okay, so the estrogen receptor or progesterone receptor. So this goes directly to what we talked about before, as opposed to measuring the estrogen levels or progesterone levels. You can measure this biomarker. So breast cancer cells with ER and or PR receptor depend on estrogen and or progesterone to grow. Testing for ER and PR is done to find out if a cancer is likely to be successfully treated with hormone therapy that stops these hormones from helping the cancer to grow. Hormonal therapy may also be called endocrine therapy. HER2, right? If you're studying for any of your boards, all of you guys have heard of that. So HER2, this is an epidermal growth factor receptor 2. How's that for a long, useless name? So yes, so you can use that one as a biomarker, and this will help to know if the cancer could be or should be treated with anti-HER2 treatment. So you're getting the sense now that, of course, there are pharmacologic interventions that are being developed for each specific receptor or gene variation or splicing or ribosomal abnormality, right? This is where they make their profits. So this test is something that you're going to find that's popular. Again, not necessarily for the diagnosis, but definitely for the treatment. And I should say, a lot of your patients are going to walk in saying to you, "Hey, doc, I was just at 23andMe. They had a sale for Father's Day. I thought I'd get it done." So realize that sometimes your patient might walk in with more information than you have, and you want to be prepared to at least make a partially educated comment on how serious they should take whatever findings they were able to get for $120. Okay, so cancer antigen, right? The 15-3, 27.29, and the CEA, right? If you're out there and you're preparing for your boards, USMLE style, the only one that's really relevant here is that CEA, the carcinoembryonic antigen. So these can be found in the blood of people with breast cancer. Problem is that abnormal levels of those biomarkers may also be a sign of another condition that is not cancer, right? So in other words, Elizabeth mentioned earlier about pancreatitis. Pancreatitis can elevate other biomarkers irrelevant of cancer. Okay, so in other words, it might be sensitive, but not very specific. Okay, let's talk about bladder cancer, right? Can anybody tell me which patient is most likely to walk in environmental wise? Habits, are there any habits that your patient might have that predispose them to bladder? I'll make it easy. Transitional cell bladder cancer. How about that for a board question? Transitional cell bladder cancer. Yep, absolutely. Smoking, says George. So, um, measurement of the tumor marker CA19-9 may be helpful in the appropriate situation if the clinical suspicion for gallbladder cancer is high. CA19.9 levels may be significantly elevated in both cholangiocarcinoma and gallbladder cancer, and the measurement can be used to correlate with the CEA. All right, still on the bladder cancer, liver function tests, right? So you can take a peek at the alkaline phosphatase, bilirubin levels, right? Because we talked a couple of times about how to take measurements of direct and indirect bilirubin, of conjugated and unconjugated bilirubin, and use those lab measurements to tell exactly where the problem might be. Liver, after the liver, in the gallbladder, after the gallbladder. So of course, you want to go ahead and do those tests also. BUN to check out the kidney, do a creatinine for the same reason, your analysis. So assess the renal function prior to performing the enhanced CT scan though. And then of course you want to do a CBC. You would expect, can anybody tell me just one lab with a CBC with regard to inflammation, right? Because cancer can be spoken about in the language of inflammation. So if I said to you, you could expect to find high levels of general inflammatory blood markers. Can anybody give me one that might pop up? Nice, Elizabeth, ESR, erythrocyte sedimentary rate. Okay, so you can expect for that to go up. You can also expect, right, that you might have certain kinds of anemia, and therefore that you want to look for erythrocyte levels, right? If you've had an increase in your erythrocyte percentage, something over 3%, some anemias that you would want to diagnose is the anemia of chronic disease, chronic inflammation, okay? So ESR is one of the markers that you could do for that. Checking out the red blood cell size, right? Looking for red blood cells that are either too large or too small. That's your mean volume, your mean corpuscular volume, your MCV. Also looking at your red blood cell distribution width, says Elizabeth. Yes, absolutely. Okay, because those are going to give you some idea of how hard your body is working to be able to replace whatever is causing the cancer. This goes directly to Sheila, your answer earlier about the leukemias of the blood, right? So you would be all over anything you can get out of a CBC on that. Ovarian cancer, right? So CA125, not good discriminators of benign lesions from malignant lesions in premenopausal women. So in other words, your patient comes in, they're premenopausal. CA125 will pick up something, but you don't know if it's benign or malignant. Scenario number 2, your patient comes in, they're postmenopausal. Now you pick up an increased level of CA-125. Now you can have a better idea that this is some kind of malignancy going on. Okay, so there is a lot of research going on to find other blood tests for early as opposed to late. Early ovarian cancer, or even the word they've come up with now is pre-cancer, like pre-diabetes, right? Some of those markers are this lysophosphatidic acid, tumor-associated glycoprotein 72 called TAG72, OVX1. Sounds like a call sign for a Star Wars fighter or something. Um, macrophage colony stimulating factor, and osteopontin. And of course, insulin-like growth factor 2, right? You guys who are studying for any boards out there, you'll know that you're used to seeing the insulin-like growth factor 1. 2 is going to be something more specific and sensitive for cancer. And then our macrophage inhibitory factor. Macrophage inhibitory factor. All right, guys. That is all we have. I hope that it's helpful for the patients that walk in and you do have some raised level of suspicion for cancer that might be going on. Any other questions, feel free to reach out to us on email, info@virtualclinic.md, or telephone. Either Jennifer or someone will pick up the phone and she will get us over to you. Well, you did it again. You wasted a half hour of your life nerding out with me, guys. So I hope it was useful. I will see you next Tuesday. Same bad time, same bad channel. Take care, guys. Bye-bye.